Good morning, good evening, good afternoon to everyone, wherever you are joining us from. It is my pleasure to introduce to you today's speaker, Dr. Kenneth Muko. He is the director of MFH's Africa programs at Learning for Humanity and Medicines for Humanity. As you know, L4H is a program of MFH. And Kenneth runs our programs all over Africa. We are present in 5 different countries, as you know. And so he has a wealth of experience in global health systems. He's a pharmacist by training, but he brings extensive experience in program implementation and capacity building across multiple countries. Through his leadership, he has supported the strengthening of health systems by closely working with local partners, ensuring that programs are not only effective, but also sustainable and community-driven. Today, he will be speaking with us about health system strengthening, an area which is critical to improving health outcomes and building resilient, responsive care systems in the communities that we serve. Please join me in welcoming Kenneth.
Thank you so much, Govinda. Hello, good afternoon, good evening, good morning, wherever you are. It's very exciting meeting you again. Listen to Govinda talk about me. I'm looking behind me. Is that really me? Yeah, my name is Kenneth Muko. I work with Govinda and Esther and Sister Beatrice at Medicines for Humanity. And it's really a pleasure having these webinars because they offer me, in particular, an opportunity to hear and learn from you guys. So when we talk of health system strengthening, next slide, Govinda. When we talk of health system strengthening, it's literally anything that has to do with health. Even if it's basic as, giving a tablet to somebody, or, for example, educating a mother. Those are different systems that are already in place, right? So the objective really is how to improve those particular services. That which is done, that which is needed to improve on what you are doing. And in the improving part, the key thing is making it to ensure that it's as comprehensive as possible for better outcomes. So it's very simple as such. Now, health systems are really not just buildings. Yes, the infrastructure is critical, but they include people, primarily people, coming together, working together, for the good of the community. Next slide, Govinda. Okay, it's a bit, yeah, just a minute here. Okay, great. According to the WHO, that's the World Health Organization, health system strengthening is the process of, first of all, identify the different parts of the health system and implementing changes. The changes might be in policy, they might be in practice, within a specific area. It might be a country's health system. It might be in a community. It might be regional. But the key phrase there, is identifying and then implementing the relevant changes, which ultimately will lead to improved health outcomes. So in a nutshell, it's simply, finding the weaknesses in a particular system, and then fixing that system, fixing those gaps, fixing whatever you feel is a weakness, so that it will not only be better, the services will not only be better, they will also be fair. Fair in the sense that, women receive equitable services as men, people who are disabled also have access to those services. But the most key important aspect of health system strengthening is to ensure that those services are long lasting, that they last for long. So, in a nutshell, it's like repairing and strengthening a woven basket. I believe we've all seen a basket lie, right? With the different strands all around it. For health system strengthening is looking at each strand to make sure that it has the right length, it fits in the right area to ensure that the basket itself comes out, as a uniform entity. Next slide. So, WHO really has come up with 6 key blocks for health system strengthening. You know, there's the service delivery, which I believe that's mostly what most of us do, right? In the clinics, the patient comes in, you diagnose the patient for whatever is he or she is sick of, you get the medications to the patient, and then the patient goes home, and the CSW follows up that patient. And then, of course, there's the health workforce, which really has to do with the people who are providing those services. Then there's the health information systems, your computers, the data you collect, how it is managed, and of course, then access to essential medications, the drugs that are given out, ensuring that they are right quality, they are stored in the right manner. And then, of course, health financing, which we struggle with every day. Where do we get the money? How do we do this? Where will the funds come from? How much do we allocate? And then finally, leadership. So we'll go into the details, within the course of this presentation. Next slide, Govinda. Okay, I think there's an issue here with my screen. Okay, it's fixed. Okay, thank you. Now, so we'll begin with self-service delivery. When we talk of service delivery, we are talking of the processes that come into play in order to ensure that health services are delivered safely, of quality, and most especially services that meet the needs of the people, not only where they need them, but also when they need them. This is very important. It won't help, for example, a mother comes into the facility, a pregnant mother, and the very first thing that the healthcare provider does, is start running an ultrasound without even looking at the vital signs, for example. You also agree with me that getting a mother into a ward that is has been assigned for pediatric, for example, the mother may receive those services there, but he will not receive the same quality as if she were in a mother's wing. So the services need to be safe, they need to be of quality, they need to meet the needs of the people who need it, and the timing is also critical. For example, a rural parish health post, for example, which is offering weekly mobile outreach clinics to reach remote villages. The question I'll ask is how easy it is for people in your community to get the healthcare they need. I mean, just reflect on this question. Are they receiving those services? And are they receiving them on time? And are the services they are receiving safe? All that comes in within the context of service delivery. Quality, safety, meeting the services on time, and the services being provided where they should be provided. Next slide. So the next block that has been defined by WHO is the health workforce. As the name implies, this has to do with people like you and I believe. All of us are an integral part of the health workforce. And this has to do with having enough trained, motivated, and supported health workers that can deliver care effectively. One, they need to be trained. They need to have the required competence. They need to know how to do their job. Secondly, they need to be motivated, whatever form that motivation takes. It might be cash, it might be non-cash, it might be, having people from the community come and recognize them, whatever it takes. To motivate them. And then, of course, they should be supported by the supervisors. Effective supervision, this one thing which I have come to realize. Most of the time we will train them, we'll give them even good salaries. At times, when we forget providing a system for effective supervision, the health workforce suffers. An example we'll give is a small rural hospital where nurses mentor local youth, for example, to become community health workers. So, how well supported and motivated are the health workers in your facility? Do they do they receive adequate support on a regular basis? Are they themselves adequately motivated? These are questions you need to ask yourself. And it's critical, it's important actually to hear from them. And one of the things which I want to point out here is that often than not, we end up just lumping all the health workers together, and coming out with one shoe fit supervision system for all of them. But that's not necessarily the case. You see improved performance when you tailor, identify the needs, the supervising needs of your healthcare workers, and put in place plans to address those needs on an individual basis. Next slide, Govina.
Oh, I just wanted to interrupt quickly and invite everyone to answer the questions, the reflection questions in the chat. Esther, if we could go back to question one.
Yeah, oh, that's good.
Go back to. So the reflection question is, how easy is it for people in your community to get the healthcare that they need? If you would like, please share your answer to this question in the chat, and I will write it down. How easy is it for people in your community to get the healthcare they need? And question number two is, one moment. Question number two is, how well supported and motivated are health workers in your facility? And of course, there are privacy concerns. If you don't want to share, you don't have to, but we would be happy to hear from you and to know what your perception is of the support and motivation of health workers in your facility. So that we can discuss and talk about that. We won't stop at this moment, but there will be time for answering questions after we cover the 6 domains here.
Thank you, Govinda. So the next critical health information, the next critical block is the health information systems. This really has to do with collecting, analyzing, and using health data to inform decisions. There is a huge difference when decisions that are made are informed by accurate data. And what I mean by accurate data is data that is well collected in a form that is usable. An example is using a simple paper to register and track the number of mothers who complete all antenatal visits. That's part of a health information system. It's not necessarily, having the laptop and the computers there. In as much as that in itself constitutes the health information system, but literally everything along the chain, from collection, from and then analysis, and then sharing that information, discussing with your team, and based on the trends that you are seeing, you now take decisions that will improve on the health outcomes of your clinic or of your program. And the question here is, what health data is collected where you work and how is it used? It's not helpful for you to collect data and you don't use it. I see this often. You know, the papers are there, people just fill in the papers, and at the end of the day, they just keep it maybe for the supervisors from the district. And at times, even they wait for the supervisors when the supervisors from the district are coming to visit or to monitor the projects. That's when they quickly rush and collect that data. The primary users of that data should be you, the people who are delivering those services. And then, of course, one of the things which I've come to realize in some of the projects I've visited where we have exceedingly very good health outcomes, where the data that is collected at the level of the clinic is also shared with people in the community. In areas where you have health area management committees at the facility, then in the community, you have like village heads or traditional leaders or elites. When that data, key data, is shared across the board to stakeholders in the community, we ended up seeing better outcomes. Why? Because it fostered community ownership and people in the community could ask questions. They could give feedback and say, this service that we are receiving, we don't like it because of X, Y, and Z. This came as a result of sharing that data. Well, I do agree that some data might be sensitive, but I believe that we all get the point that, key data related to key services, related to outcomes, for example, that's data which you could, easily share across the board to stakeholders, including those in the community. Next slide. Access to medicines and technologies. I know this is what, for the most part, people will always ask for. Oh, we have no drugs. We don't have drugs. We don't have enough drugs. And then you go to the drugstore, you see cartons of metronidazole. And then, the next shelf, you only probably find like two blisters of paracetamol, for example. When we talk of access to medicines and technologies, we are referring to a state where people have reliable access to safe, effective medications, vaccines, medical equipment in the right quantity at the right time. The drugs should be in the right quantities, the right quality, available at the right time. They could be there. This is another thing that I've seen. You go in the main drugstore, the drugs are there, right? But because of poor planning, for example, in the dispensary, there are issues there. Or the drug might be in a different dosage form, for example, but it's the same drug. But because it is a different dosage form, it ends up not being appropriately used for the right indication. An example is nearby clinics are coordinating to share emergency medicines when one runs out, for example. This is an example. The reflection question is here is what challenges does your facility face in getting and keeping needed medicines or equipment? And I like the part about keeping. We all agree that we do have several medications which need to be preserved under certain specific temperature, uh, specific climate conditions. Yeah, so all that falls within the access to medicines and technologies. If the insulin, for example, is not stored in the fridge, of course, you agree that even though the vial of insulin is there, and it's kept in the sun because there's no refrigerator, or the vaccines are, for example, at the end of the day, the patients will not have the specific medication which will be effective to treat, maybe diabetes or to vaccinate that child. Next slide, please. Financing. I believe that literally every one of us, with USAID being shut down and the EU governments cutting down on budgets for literally across all the projects I've been visiting, this is a cry, even for us as an organization. Financing. How do we make sure that enough funding is available? Enough funding and resources are not only available, they are used wisely and fairly. How do we, balance the budgets, especially in periods like this where access to funding is it's a huge challenge. As the example we have here is a community is raising funds to repair a broken water pump at the health center, for example. And the reflection question is how sustainable is the funding for healthcare in your community? Remember, it's not only having the funds, but it's also making sure that the funds are used in a way that it is sustainable. Typically at MFH, we have gotten to a point where the way we design projects now, we try to allocate as much money as possible to activities that are sustainable. For example, trainings. We know once you do the training, there may be need for refresher training, but for the most part, that information remains in the community, except the person moves away. When you buy an equipment, if there's a proper maintenance plan in place, that equipment will last, for at least a couple of years. You don't have to be doing it every day. And then the most interesting part of most of our programs are economic strengthening activities, which we try to integrate into our programs. This all comes under the financing block. Next slide, please. Leadership and governance. This really has to do with policies. It really has to do with the higher level management. It has to do with accountability to ensure, that the programs are managed in a way that the donor, when he comes to visit or when he receives the donor report, he or she will say, yeah, this is a job that has been well done. So the right policies need to be in place. Policies for staff management, for example, or finance management, systems in place to ensure accountability. How are purchases and procurements made? An example here is a sister serving on the local health committee to help set up clinic priorities. Because of course there will always be different priorities, at times conflicting. And what I want you to reflect on is how are decisions made in your health facility or program and who is involved? who's involved, for example, in setting those priorities. Next slide, Govinda. I think it's time for questions, right?
Yes, it's time for questions, and there are several comments in the chat if you would like to look at them as well. But we are inviting now questions if you need clarification, if you have an example that you would like to share that is specific about health system strengthening when something was weak, one of these domains was weak, and how your organization strengthened it or how you plan to strengthen it. And if you have any other focused questions focused on this topic.
Govinda, how are we doing time-wise? How much time do we still?
We we are good, very good time-wise. We have
Oh,
another
perfect.
30 minutes, and um, coming up, we have the gap analysis.
Okay. Great. Govinda, you want to read some of the comments?
Yes.
I
So
can see one from Laurie Moise.
uh-huh. I'm gonna come back and see any comments over here. Lori posted a few comments actually answering all of the questions and talking about service delivery specifically. She talks about I believe Lori is in Haiti, and she talks about the insecurity and gangs make the transportation risky and expensive. Most health facilities around us have closed or have decreased health services. Health professionals have left the area because of kidnappings, and there are less professionals. The people have lowered income, and their funds must go to food. I think this is the case for a lot of the organizations in Haiti as well as ours. Kenneth, would you like to say a few words on that?
Yes, no, absolutely. I agree with you. Unfortunately, Laurie, this is what we see in conflict ridden areas. We see that in Haiti in our programs. We see it in the Democratic Republic of Congo. We see that also in parts of Cameroon. But I'll tell you one thing, though, which I really appreciate has been the resilience of the sisters, that in most of these areas where there's been high insecurity, the sisters still remain for the most part. For the most part, so in as much as there are those challenges, what we tend to do as an organization is identify and look at ways of strengthening those facilities that are run and managed by sisters, because for in most of the areas where we are working, where there's high insecurity, the programs run by the sisters still in place. Apparently, there is a lot more respect, for the sisters than for the government-run programs. But I agree with you, Laurie. It's a challenging context there.
Mhm. And unfortunately, it's not always even the case in the sister-run facilities, but it is a lot better. Um, Another person's Teresa John is talking about the health workforce and how they're not given proper training or support. Could you talk a little bit about ways to get training, Kenneth? And also, I'll talk about learning for humanity as well.
Oh, that's what I wanted to talk about, Gavina. Well, right now, thankfully, with access to internet and technology, it's very easy for you to find courses that are free online. If I were running a program, that would be the first place I would go to. Go online, look at the WHO websites, look at former USAID. They did have very great learning opportunities. UNICEF also had several of them. So that's where I will go to first. Now, beyond that, it is clear that because of the nature of some of the programs that we run, there may be some competencies that are very specific for particular programs. Take, for example, our program in Zambia. We are doing healthy babies breathe and helping babies survive. The courses out there are either paid or very limited in terms of the context. So we now have to do trainings. So what this means is that when you are designing your programs for those kinds of professional development needs, you will need to allocate funding for them. And there are ways to do that. You can organize workshops, or you can even plan to send some of your staff to other organizations that are organizing those kind of workshops. One of the things which is very common these days are the conferences. In most of the health conferences, well, not all of them, but most of them, they do have mini workshops to help build professional career and also build skills, knowledge and skills for health workers. So those are things you could also take advantage of. Govinda?
I wanted to highlight the Learning for Humanity program, of course, which most of you here are a part of. Your employees can also take our courses, or you can do the courses yourself, and then you can hold a workshop in your own facility and teach what you think is the most important because they may not need all of the information. As you know, our courses are very dense and long and involved. But I want to speak to someone else stating that,
Govinda, let me just quickly chip in something before you
yes,
move forward in
please, please.
regards to professional development. One of the things I want to caution managers, program managers, especially those who manage projects when it comes to health worker, building the capacity, is to look for ways to ensure that the staff stay. Yeah, we mentioned motivation, right? But in some instances, especially when it has to do with the sisters, unfortunately, because of the nature of their work, we find situations where we are working on a program. We have sent sisters for training, or we train them as nurses or midwives, and they come in because, well, we train them because we expect that they will come in and work on the project. But when they come in, 1, 2 years, they are transferred to other communities. So you need to take this into consideration. One of the things that we did in Zambia is that since we're working through the dioceses, and then we had to train sisters from specific congregations, we got the leadership of the congregations to sign memorandum of understandings or contract agreements which will stipulate that when the sister comes out of school after training, she will need to work on the project for minimum 4 or 5 years. That ensures that that knowledge that she has gained will be used in the project, and it gives us time also to prepare for her departure, which means we'll now look at the possibility of training other sisters. So I just wanted to bring this up, Govinda.
Thank you so much. I also want to add, there's another comment in the chat that says the data is collected. So speaking about data collection, the data is collected and not worked on by the responsible people. And this is where it's extremely important to have clear job descriptions and to
Mm,
monitor employees. This is
mm,
where weekly meetings can be very effective in asking the team, where are you with this task? How much has been done? What still needs to be done? Those are
yeah,
those are monitoring essentials of knowing where every individual is on their tasks. Go ahead, Ken.
right. Absolutely. Absolutely. That's a great point that's been raised there. Uh, I will advise that in your facility, irrespective of how small it is important to have someone, maybe a point person, if it's a very small facility, it's important to have somebody who will be in charge of the data. If it's a larger programs, typically big programs, they will have an M&E, a monitoring and evaluation officer. Now, when when you start going down to smaller facilities because of lack of resources, you may not be able to have a full-time position. But it's important to have somebody who is a point person, and that point person must not. I would recommend that he should not even be the health center in charge or the manager or the director. It should be one of the staff whose job really is, and like I said, definitely this is not a full-time responsibility because of, I know that the smaller facilities will not have enough staff. But that person's role really will be to ensure that, to follow up, to ensure that that data is collected appropriately in the different units. And the key thing, the key role of that person is to collect the data and kind of do some preliminary analysis so that by the time he's coming into the meetings, your meetings, he's saying, okay, these are the trends. Okay, this is what is happening in this wing, in this ward. I suspect that there may be a problem, and then that will generate a discussion. And then from that discussion, it will now generate some decisions that will be taken to remedy the situation, if it's so, to address it or to improve on it. But that's a very good point that's been raised.
I'm going to address one more comment in the chat, and then we're going to move on to the gap analysis. Um, Elizabeth says there's a lot of medication and equipment that are left to go to waste. Managers have to check and share such things with facilities to make good of the goodwill of the donors. And this is where it's extremely important to make sure that you're using your supplies and those soft supplies that are coming in and those usable assets, and make sure that they're being used. And that requires, again, monitoring. It doesn't have to be an M&E person. It's just someone that's in the pharmacy or knows where the storage facility is and is able to have a look. Also, this is a task that a manager can ask every week. What do we have too much of? What do we have too little of? Even if you're not able to purchase things, at least you know what you have in that moment. So it
Yeah.
requires asking the correct questions. Go ahead,
Yeah.
Kenneth.
Yes, no, absolutely. That's an excellent, issue that has been raised there. I told you that the reason I love this webinar is that I end up learning, a lot. So thanks very much. The one of the courses we have for L4H, I believe all of us know, has to do with management, and within that is managing drug supply. And I think that for a health facility, those of us who are coming from health facilities, it's important that at least one person, preferably the person who is managing the drugstore or the person who is managing the pharmacy itself, enrolls, attends, and completes this course. Because, yeah, the issue of wastage at times comes as a result of poor calculations, poor anticipation of the needs. But that being said, for most of the church facilities, there is this other aspect of donations which come in, be it from Europe or from, wherever, in addition to the drugs that have been purchased, which I regularly purchase. So some of the facilities I visit, I go in the drugstore and you find this huge quantity of drugs that were just donated. And you are right, the person who donated it, does it with a good mind, good intentions. But at times, those drugs may not be exactly what is needed. So a word of caution here is that in as much as it's good to receive donated drugs, but what's more important is to make sure that what you are receiving is useful for your facility. Because you may think it's free, but no, 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 it's not free. Once it gets bad, remember, you need to discard it. I mean, even for the drugs to occupy your space in your store, that is a cost. The staff who are managing those drugs that have been donated, that is a cost. So it's not really free as such. One of my suggestions is that not to remedy this problem is given that for the most part, uh, the partners, the health facilities, they speak to each other. Once you know that you've received a large donation, I see this for some of the sites I visit. Well, it'd be a good thing to just call the sister facility, and then share it, give them some of it before they get expired. Governor.
Thank you so much. We'll move on to the next bit. We have approximately 18 minutes left. And 4 slides, so approximately like 3 minutes per slide, Kenneth, and then we can have some time at the end for questions.
Okay, great. For me, talking about gap analysis, for me, it's a very critical aspect of health system strengthening. You can only strengthen what you know, and you can only strengthen the weaknesses. You can only improve by adding on things that are lacking. So defining the gap is very critical, is very important. And what we mean by defining the gap is just by comparing what you have with what you need. That way you can see where improvements are needed. This is what I have. Okay, right now we have the infrastructure is there, the buildings are there. Now we have equipment, for example, for a theater. The theater is there, the equipment are in place. Depending on the level of the theater, you now realize that the surgical services that are needed, you don't have a surgeon, for example. You may have a medical doctor who has been, may do basic things like hernia, but you want to improve, do more complicated procedures. Clearly, your gap there is to get a surgeon. By the way, gap analysis, well, probably this may come in later on. But why this is important is that it helps you to focus your efforts. It helps you to hone in on what is most needed. Remember that for the most part, the resources are always limited. To be honest with you, I've never visited a health facility where they will say, no, we have enough money. The resources are very limited. Uh, Even when the resources are available to meet up with the required services, there is always the need and push to expand. I see this mostly with the faith-based facilities. We go in as MFH, we build the health system, and then the Ministry of Health comes in. It decides to upgrade that facility from a health center. That's where we started. It's now sorry, let me put it this way: from a primary um, health level, it's now upgraded to a secondary health level, and the when that is done, there's now need for more resources, more staff, more equipment. So doing a gap analysis really helps you to focus your efforts on where they will have the most impact. After you've done your gap analysis, what you do, you ensure that the things that you will do to address those gaps effectively will have the highest impact. It's like checking which threads. Remember our woven basket, right? It's like checking which of the threads on the woven baskets are strong, which of them are broken and need to be replaced, which of them need to be strengthened. That's what we mean by gap analysis. Next slide. So, how do we conduct a simple gap analysis? First of all, given that most of us come from very facilities that are much smaller. There is it's you can use a very simple process. Just call your key staff and then just hold a meeting and then ask each of the heads of each of the units, say pharmacy, the consultation unit, the antenatal care, the postnatal care, and you simply ask yourself this question: where would you want this facility, your unit, to be in 1 year or 2 years time? And then you now step back and ask, so what is needed? And then you now, based on the needs, you now prioritize them. That's for a very simple, health facility. With a couple of meetings, you can be able to identify gaps and weaknesses. And then after that, you now draw a plan. But for the more complex or larger facilities, there's this step-by-step process that is usually recommended. The first thing is you choose a framework. There are different frameworks out there, but the WHO building blocks framework has been reputed to be one of the best. Many people like it because it clearly distinguishes one block from another, and with really detailed descriptions and clear understanding. So the next step that you need to do is to try to describe what the situation is. Try to have an understanding of what is happening in each of the block. This might be done by simply asking basic questions to the staff who are working there. Another thing that could be done, in order to understand the situation is you can even use a small questionnaire that's in a more sophisticated facility or program. Come up with a simple questionnaire, which you now administer, be it to staff or even be it to patients, or even a combination of staff and patients. You may even, in some cases, even you may even need to talk to other stakeholders that are involved in your facility. But the key and most important part when it comes to describing the current situation is to make sure that you involve as many people as possible who have something to do with that service. After that, you now have to define what the situation looks like. Oh, sorry, you now have to define what the desired situation looks like by asking yourself this question: what should it look like if it were to be strong? If it were strengthened, what will it look like? What do you desire to see? It may be something as simple as that, as at the end of this maybe 1 month, I want to be able to ensure that every patient who comes into the facility passes through all the key different units within 30 minutes. That's assuming that you are working in a facility where there is a, patient wait time is very long. you know, if that is your desire, that could be like what you want it to look like, after a specific period of time. You now need, assuming that is the case, you now need to go and ask yourself, where is the delay coming from? Do we need to add another nurse at this particular time? Or maybe the nurses are there, but unfortunately they have only one a BP apparatus, for example. Or maybe in the laboratory, there's a long wait time there because there's just one microscope. So when this has been identified, that's when you now look at how to address that gap. That gap, like I said, it's a difference between what you desire to see and what the current situation is. And addressing that gap comes with specific action steps that are time bound, action steps with clear responsibilities, uh, for specific people. And yes, of course, there will always be need for a budget that is allocated to address those gaps. Next slide. So an example using the WHO framework and the WHO service delivery block. Yep, right. Yep. So I believe I explained this a little bit. Patients wait for 4 hours, for example, and you desire to see that the patients are seen within 1 hour. So your gap there is a long waiting time. Like I said, the question is, why is that long the waiting time? It might be limited staff, or it might even be the staff may be there, but they don't have the appropriate knowledge and skills for that particular service. So what that means is that you probably need to either get staff with the required knowledge and skills, or you train those staff. You provide them with additional training to build up their skills. It might be lack of equipment. You address that. And it might also be motivation. The staff may be there. They may have the required knowledge and skills, but they are just not motivated. So that will be your gap. And then you now define what your actions will be right through until you now have the desired outcomes. And remember that even within this process will require monitoring as well. The plan that you've developed, you need to monitor it to ensure that it's done in time, is done the right way. Next slide. I think there's one more. Okay. So the case study we have is about St. Mary, which is a rural health post, which is serving 12 surrounding villages. And recently, there have been lots of reports of stockouts of essential medicines. And, patients are traveling from long distances, some up to 15 kilometers. The staff are overworked. At times, you only have one nurse and one community health worker. The registers that are being used are really paper registers. They are either incomplete or some of them are missing. The pages are missing. And then, of course, there's limited engagement from local leaders in the planning, not only in the planning, but also in the supportive services in the community. So the question is, which of the WHO building blocks are weakest in this case? Anybody? Which WHO building blocks are weakest in this case? Is it leadership? Is it health force? And what two practical actions will be needed, you know, to improve on the system, to strengthen the system? Well, just reflect on this and write your answers on the chat. Govina, I think we have like 6 minutes. Can we take questions? Are there any questions or comments?
We have one person in the chat that said the health workforce, and that is correct. That is one of the building blocks that is the weakest in um would you agree, Kenneth?
Yes, absolutely. Absolutely. The health workforce is critical there. Yeah.
And so in the chat, we also have leadership. Someone said leadership. And in the chat, if you would like to add the final question, what two practical actions could the clinic take to strengthen the health system? So if you were in this position, what would you do to strengthen the health system? And we have 5 minutes left, but I actually want to highlight a previous example that Lori put in the chat. And I'll summarize. She said our pharmacy was weak, running out of meds, possibly stealing. Meds were going expired before they were used, and they were also wasted. They they did a gap analysis. Some maybe didn't call it that at the time, but did a gap analysis. What are the possible things that are happening? They sent a pharmacy aide, they sent a young person to pharmacy aide school, and then the administrator of the facility included oversight of the pharmacy into the weekly meetings of the facility to identify issues, brainstorm solutions, and implement the solution, as well as evaluate and do continual follow up. But this is why I want to highlight the story. They went from an error rate in their pharmacy of 38% to 3%. And they
Oh, wow.
constantly monitor to keep the error rate to under 5%,
Oh,
which is
wow.
absolutely an incredible example
Fantastic.
of using basic surveillance and health system strengthening to identify a problem and think within solutions instead
Yeah.
of focusing on the problem. It's deconstructing what is the root cause of the problem. How can we address this with the resources that we already
Mm.
have because we know that we won't be getting new resources? How do we address this? They trained someone, they came together, they facilitated sessions, and they worked together as a team. So incredible work, and thank you so much for sharing that. And we have just a couple minutes for one more comment. Otherwise, Kenneth, do you have other words? Esther, you can go to the next slide. Correct. Thank you.
Okay, great. No, I think really it's always a pleasure being invited by Govinda, Esther, and Sister Beatrice, to participate in these webinars. Like I said, I'm taking notes. I've been taking notes from what the feedback I've been receiving, which is really going to go a long way in helping to build my understanding as well on what is happening on the ground. I'm
We
always
do have,
available.
sorry,
Yeah.
go ahead.
Is there a question?
No, I just wanted to say that we do have one person who answered the question, and what they would do is they would train more nurses to reduce the workload. So
Yeah,
thank you for that
absolutely.
contribution. You were going to share your availability.
No, I was just saying that I'm always available whenever you need me, and it's always a pleasure to interact with the sisters and learn more what is happening.
Sisters, thank you so much. Sisters and students, I know that not all of you are sisters. Thank you so much, Kenneth, for that insightful and engaging session and for sharing your expertise on health system strengthening with us. I invite everyone to turn on their camera so that we can take a picture. I also want to thank all of you for your active participation. It was wonderful to see such strong engagement, thoughtful questions, and sharing your experiences throughout the discussion. This kind of participation is really what truly makes Learning for Humanity special, and I truly appreciate you being vulnerable and open to contributing and to sharing so that we can all learn from each other. We hope that today's session provided you with a practical insight and an inspiration that you can apply to teach others within your facility and to brainstorm with others as well. Thank you again for joining us, and we look forward to seeing you at our next community talk next week. We are doing our third session on on mental health and psychosocial support. One moment, I haven't taken the picture, so bear with me. Oh, Kenneth, your camera's not on. Do you want to try to get that on? If
It,
you
it,
can.
it looks on here.
It hasn't been on the whole time, but it was absolutely fine because we were hearing you loud and clear.
Oh, okay. I see. Oh, what's the problem? Oh boy. Yeah, I see what you mean. All right, right. Yeah.
Oh, there you
That's
are.
that's how I
Everyone can
look.
see Kenneth now. I'm going to take one more picture. 1, 2, and 3. Thank you so much to everyone for coming, and we look forward to seeing you next week. If you have questions, email us and we'll get those answered. If you have more questions about this topic, we will answer your questions. Thank you. Have a wonderful rest of your day.
Thank
Thank
you.
you.
Thank you. Thank you.
Thank you.
Bye-bye.
Bye.
Bye
Thank you,
bye.
Esther.
Bye bye.
Yeah. Thank you, Mr. Simcoe.
Thank you.